Thanks very much, Shahid. Thanks again to Helen, and great to be here today. So I'm going to romp through the UK pilots for liver transplantation. So there's two categories of patients that this applies to, and I think a key thing to highlight very early on is these are people that have already been deemed irresectable by an HPV MDT, although I know there's some grey around that as in terms of that decision making. And the second point is that they've not been downstage, so they have to always have been within criteria. And there's two groups of patients, with those with small intrahepatic cholangiocarcinoma and those with perihilar cholangiocarcinoma on the background of PSC. So these pilots have been set up for a number of new indications that have been brought in for liver transplant. Current examples would be patients with isolated metastases, liver metastases from colorectal cancer, or from neuroendocrine tumours. And they're a service evaluation, not research, although there's some caveats that relate to perihilar cholangiocarcinoma. And what the purpose of them is to evaluate whether international experience can be replicated within the UK, and then make a decision as to whether this should be accepted as a routine indication. And there's been a well-trodden path. There have been new indications that have been brought in, like the expansion of the HCC criteria, acute on chronic liver failures. So the first group of patients are those patients with very early intrahepatic cholangiocarcinoma, and this pilot opened in February of 2023. It took a long time to get to the point that we opened, and it was a real multi-professional effort to get to that point. The pilot for this, the definitions were based on that from the Sapashin paper from 2016, where there was a single tumour less than 2 centimetres in size. It needed to be biopsy proven, and as I say, resection had to be deemed not feasible. And there was exclusion based on mixed patterns of tumours. There was a review that took place in 2025 of all the new cancer indications, including the ones that I've already mentioned, and that included reviewing the entry criteria into the pilot, and the consequence of that was that there was a revision up of the inclusion criteria to 3 centimetres, which is in line with the ILCA and EASL guidance. It was accepted that prior systemic therapy would be allowed, provided that it wasn't downstaging, and that while the people were waiting on the waiting list, it was reasonable for centres to consider local regional therapy to bridge to transplantation. The patient pathway for intrahepatic cholangiocarcinoma is relatively straightforward compared to the perihilar cholangiocarcinoma. The patients, as mentioned, have come through the cancer MDT to the transplant MDT and would be listed. There's no neoadjuvant therapy that's mandated or built into the pathway. They have a standardised staging assessment. A biopsy is required. The aim is they're given a level of prioritisation to try and make available an organ within 3 months, although centres are encouraged to use organs that are outside the named patient offering system, so more marginal extended criteria donor organs. If the patient isn't transplanted by 3 months, then they're restaged, and if still within criteria, they would continue to wait. After transplant, there's scheduled and planned surveillance up to 5 years, and the aim of assessing the pilot was to look at outcomes, and the outcomes of interest are listed here, and this was published, the kind of protocol was published in Hepatoma Research that summarises the approach that was taken. In terms of accruals, so despite the expansion of the criteria, as of the end of April, there have only been 3 patients registered so far, so that's 1 patient a year in essence. In fact, 2 were registered under the less than 2 centimetre criteria in 2021 2023, one in 2024, and then and both of those were transplanted within 3 months, within 90 days. And there's one patient who was registered a couple of months ago who's continuing to wait on the waiting list at present. In terms of the perihilar cholangiocarcinoma, this is only for patients with PSC, as I mentioned. This pilot took longer to open. We've already heard Maria mention the emphatic study, so it's a commissioning evaluation. It had to go through all the standard approaches of opening a clinical trial. The transplant centres were identified as PIC sites and had to be opened as PIC sites. So there was a delay in getting up and running with this. And this is the inclusion criteria, which are similar to those from the Mayo, with one significant difference, which is that there needs to be a positive diagnosis with cytology or cholangioscopic biopsies, or even EUS FNB biopsies, which in some programs is deemed to be an exclusion if if a tumour has been punctured from within the bowel. And the exclusion criteria are listed here. As I mentioned, it's just the entry criteria are similar to the Mayo protocol. In the Mayo, you don't need to have confirmed cytology. There are those patients where it's thought there's a very high likelihood of this being cancerous. And an essential part of the perihilar cholangiocarcinoma protocol is the use of neoadjuvant therapy. And in the Mayo protocol, that's brachytherapy, which we don't really have reliably available in the UK, with external beam radiotherapy and chemotherapy simultaneously. And then ongoing chemotherapy until the time of transplantation. The reason that PSC the PSC patients were selected is summarised in this review of the Mayo experience. Just a couple of things to highlight. So overall, the outcomes for those patients who are transplanted within the Mayo criteria at 5 years are about 70%, 60% at 10 years. But it's really important to highlight that even those patients embarking on neoadjuvant therapy with intent to transplant, the dropout rate is really significant. So over a third of patients don't get to liver transplantation, even if they're within transplant criteria at the point of listing. And what was demonstrated from the Mayo data is that if you look at the comparison between the PSC patients and the patients with de novo cholangiocarcinoma, the outcomes for patients with PSC were more favourable, and the risk of recurrence in red is lower, around 20% at 5 and 10 years. So because this was an attempt to re-establish cholangiocarcinoma as an accepted indication in the UK, it was favoured that we would start initially with the PSC patients and then consider expansion to de novo patients in addition. This meta-analysis, I think, just backs up the guidance or the vision that the Mayo had in establishing the protocol. It's from Edinburgh, and I think what it demonstrates is that in 20 studies, including 200 patients, almost more than half of them from the Mayo, is if you compare the outcomes, there's no randomized trials, but if you compare the outcomes of those patients who are transplanted with after neoadjuvant therapy versus those that had liver transplant alone within criteria, there's really a very dramatic difference in outcomes. So the key message is that neoadjuvant therapy is really critical in developing this protocol. And as mentioned, brachytherapy was not available in the UK. So in the implementation group, there was quite significant discussion about how this should be taken forward, and it was recommended that proton beam therapy should be built into the pathway. And as Maria, who's the chief investigator, highlighted early on, This we've managed to get the support of NHS England to build into the pathway as a commissioning evaluation, although it's been used for patients with cholangiocarcinoma before in the study, one of the studies that Maria commented on. This is the first time it's been used within a transplant protocol. And because of that, NHS England require that it's developed as a commissioning evaluation in a structured way, in the same way a clinical trial would be undertaken. And at the end of that commissioning evaluation, if the outcomes are favourable, it should allow the service to be commissioned as part of this pathway. So we had to go through all these hoops of getting started as a clinical trial. And I say it's single arm. The aim is to recruit 25 to 30 patients over 2 to 3 years, and then follow up for a couple of years. The primary objective is to assess the safety and feasibility of the neoadjuvant therapy. So the transplant is not part of the trial. It's really focused on the neoadjuvant therapy. And the primary endpoint is around toxicity and successfully getting patients to transplant and to survival 90 days later. We've already seen this slide. I wasn't going to dwell on it, but I guess it's to really draw comparison with the intrahepatic cholangiocarcinoma pathway in terms of its complexity, and I think Maria alluded to that already. There's the emphatic portion of the study is here, but there's a requirement for ongoing chemotherapy while patients are waiting on the list with GemCis up at 6 cycles up until the time of transplant. And the aim is to undertake transplant within 3 months of listing. We've heard mention of equity earlier today and in yesterday's discussions. And I think one of the things that we were pleased to achieve in the setup of the study was agreement across all 4 nations to support and fund this commissioning evaluation. So patients in Northern Ireland, Scotland and Wales can access this treatment. But with only 2 proton beam centres, it's a very complex and kind of expensive path for the patients to navigate from maybe the local hospital to the HPB centre to the transplant centre to the PB centre, back to the transplant centre, and thereafter follow up in the transplant centre. So it's quite a challenging pathway to deliver. As I mentioned, the transplant centres are not trial sites, they're PIC sites, so they're identifying the patients and they've got the responsibility to work up the patients in a standardised way, which is summarised here. This includes the radiological assessment up to the neoadjuvant therapy, so up to the point of referral on, then after the neoadjuvant therapy restaging, then activation on the list, and then monitoring on the list. So if they haven't been transplanted within 3 months, they're restaged at that point. And the other really critical point is that we need to be as confident as we can be that there's no extrahepatic disease at the point that the patients are registered for transplant. So all patients should have an EUS evaluation, sampling of perihilar nodes to ensure that there's no extrahepatic disease. And again, it just adds to the complexity of the pathway. Oh, yes. So once the transplant centres have completed the workup, they refer into the National Proton portal, and thereafter there's an MDT discussion about their suitability for inclusion in the protocol. And Marie and I have been discussing ways in which we can really tighten that up to be sure that there's a really good alignment between the transplant care and the proton care across the country, just in a standardised way. In terms of accruals in the perihilar cholangiocarcinoma pilot, This is data, again, up until the end of April, and this relates only to the patients that have been added to the transplant list. There have been 4 patients from 3 centres that have been registered, and all of those ones have been treated in UCLH. One of those patients was within emphatic. 3 of them had treatment outside of emphatic through a kind of appeal for funding, so they're not actually within the emphatic study that I mentioned. Of those 4 patients who've made it on the list, 3 of them have been transplanted, all within 90 days, and that was one of our big concerns. Would it be feasible to get these patients transplanted in a timely way with the growing transplant list and the reduction in access to organs? And one patient who was treated outside the protocol, so not in a kind of timed pathway, had their transplant aborted after they were found to have extrahepatic spread at the time of laparotomy for their transplant. So just to finish, the final thing to say is what have we learned so far? So obviously we're still on a bit of a journey here. I think the ICC, I've already mentioned, there's low recruitment, and that doesn't seem to have increased since the revision of the criteria. And we've really been trying through HPB meetings, medical gastroenterology, hepatology meetings, patient meetings to promote these pilots, just to make people aware of them. But that hasn't really translated into an increase in numbers as yet. I think there's been a lot more learning in the perihilar cholangiocarcinoma pilot, and I think that just reflects the complexity. As I say, there's a high rate of dropout, and given the patients are moving between centres for their care, what we've seen is some really quite challenging, all well-intentioned, but quite challenging communication with the patients and difficulties in terms of managing expectations as the patients are moving their way through this pathway with this concern that some of them will not even get to the point of transplantation. I think again, benignly intended comment, but I think the oncologists come from a view that they're trying to provide access to treatment for patients, so a permissive approach to trying to get patients treated, whereas given the restriction we have on organ donation and access to organs, we've really got to be tight on which patients we treat. And sometimes that sort of differing philosophies can lead to difficulties with communication with the patient and also maybe amongst the clinicians as well. It's essential to have a tissue diagnosis, and with the increased use of cholangioscopy and with the background of PSC and diffuse strictures within the biliary tree, we see that exacerbating the cholestasis the patients have, making it more difficult to expose them to neoadjuvant therapy, and that's been a challenge. The recognition that it's reasonably easy to be fit enough for the PBT, but not necessarily for the other aspects of the neoadjuvant therapy, and it's about actually being eligible for the whole course of neoadjuvant therapy to allow people to be eligible. And this is one of the topics that I'll be catching up with Maria today, which is just ensuring the complex pathway is followed consistently across all centres so we can appropriately compare the outcomes at the end. And a couple of sort of points that have been picked up. Obviously, the distal bile, these patients are having Roux-en-Y biliary anastomosis. The distal bile duct's being left in place. It's really important. We've seen a couple of patients with high-grade dysplasia to the margin. And given the patients are having ERCPs and assessment, it's really important to fully evaluate the distal bile duct. So we've got, going into the planning of treatment, we know the extent of the disease. In the absence of a mass, the longitudinal extent of a tumour is not preclusionary for being included in the protocol, but it's really important to know if there's any distal diseases in terms of planning their ongoing care. And then we've seen, again, because of the history of PSC, the history of inflammatory bowel disease, some of these patients have had colectomy and really made laparoscopy unsuitable. And it's essential that a backup patient is in place when transplant's being undertaken in case, as was seen in the fourth patient in the Perry-Heiler protocol, the transplant can't proceed and a backup patient can be transplanted. So with that, I think I'm finished. Just to acknowledge the work of everyone that's been involved in establishing the pilot. We've got there, we're still learning, and happy to take any questions. Thanks.